Welcome to Falcon Physician Review's Neurology Review session for Step 1. The next module will cover vision. This is a very important module which will be something that you'll take with you into your clinical practice because you're going to be able to need to know where the lesion is if you see a particular visual field deficit in your patient. So first let's talk about what happens when light hits the retina. The retina contains two types of cells. One are rods and the other is cones. Rods are primarily concentrated out in the periphery and are important for night vision. Cones are concentrated in the macula and are important for color vision and high acuity vision. Information is passed through the retina where it arrives in the retinal ganglion cells. These are the cells that create the axons that make up the optic nerve. The optic nerve travels back to the optic chiasm where part of the fibers will cross to the other side. Then it will create the optic tract. This is the part of the fibers that are behind or posterior to the optic chiasm. The end of the optic tract is the lateral geniculate nucleus, or LGN. There a synapse will occur and fibers will then project to the visual cortex. The LGN is considered a thalamic nucleus, even though it's technically outside of the thalamus. But as you'll see, almost all of our sensory systems stop in the thalamus on its way to primary cortex. What does the LGN look like? Well, this picture shown here is a coronal section of the brain, and right next to the hippocampus is a circle that shows where the LGN is. This LGN has a very particular structure to it, where it looks like a Napoleon hat. Here's a zoomed-in view of it, where you'll see the Napoleon hat circled by a red circle. If you don't believe that it looks like a Napoleon hat, here is something that I've added to it to make it clear to you that this does look like a Napoleon hat, and you should remember that any time you see something that looks like this, it's likely to be the LGN. What happens next? Well, LGN projects to visual cortex, but it doesn't do it in a simple manner. The superior visual field, which corresponds to the inferior retina, will actually project into Meyer's loop via the temporal lobe. So this is an important feature that you know that if a person has a temporal lobectomy, for example, for epilepsy surgery, they may actually have a visual field deficit that would be in the superior visual field. This information will proceed to the lower bank of the calcarine sulcus, that is the lingual gyrus. I'll show you that in a subsequent slide. Next, we want to see what happens to the inferior visual field. The inferior visual field, after synapsing in the LGN, will project into the upper bank of the calcarine. Now, the radiations, the optic radiations, where this information is traveling, are not named. Whereas the Meyer's loop is for the superior visual field. The upper optic radiations don't have a name. You can just call them the superior optic radiations, but know that they will end in the cuneus gyrus of the occipital lobe. Here's a picture of the calcarine sulcus. The red arrow depicts the calcarine sulcus, and the superior gyrus of that would be the cuneate gyrus, and the lower gyrus of that would be the lingual gyrus. Now, here's another schematic of seeing the different pathways that light or that visual information takes to make it to the occipital lobe. Here you see the optic tract, the optic chiasm, and the LGN and the optic radiations. We have both Meyer's loop and the superior optic radiations represented here. Here's the primary schematic that you would use to determine what a visual field deficit looks like when a person has a lesion in one of these numbered areas. Lesion number 1 is quite simple. It's just a lesion of the optic nerve, so if a person had his eyeball scooped out with a melon baller, of course you're not going to be able to see out of that eye. That's very simple to understand. You don't have to do much memorization to remember that an optic nerve lesion leads to monocular blindness of that one eye that had an optic nerve damage. Lesion number 2 is smack dab in the center of the optic chiasm. So that is a bitemporal hemianopsia. Those are affecting that lesion affects both crossing fibers, and the ones that are crossing are both the temporal visual fields. Therefore, the part that you're unable to see when you have an optic chiasm lesion are the two lateralmost sides of both eyes, of both visual fields. Therefore, you have something that approximates tunnel vision. You're able to see the very central of your visual field, but you cannot see the lateral sides if you have an optic chiasm lesion. Lesion number 3 is of the optic tract on the right side. Now, if I have a lesion on the right side damaging everything that's going over to the right side of my brain, the way to remember what kind of visual field deficit I would have is that I would not be able to see anything in the contralateral visual field, either up or down on that side. So what I would have is a left homonymous hemianopsia. I would not be able to see anything on the left side. Cover my right eye, I still can't see anything on the left side. Cover my left eye, I still can't see anything on my left side. So that a homonymous hemianopsia is. Okay. Now, if I lesion number 4, the Myers loop on the right side, the type of damage that I'm going to get is in the left superior quadrant on both eyes. I'm not going to be able to see anything in the left superior quadrant of both eyes. The way to remember that, again, is that everything in the brain is opposite to the amount of damage that you're going to get in the visual field. So if I have a damage in my lower right side of my brain, the part of the visual field that I'm not going to be able to see is the upper left portion of my visual field. So apply that to lesion number 5. Lesion number 5 is the superior optic radiations on the right side. If I have a lesion in my right superior portion of my brain, the part that I cannot see of my visual field is the left inferior portion of either eye, using either eye. So if I look at lesion number 6, that is a lesion of the occipital cortex on the right side. That is essentially the same type of visual field deficit that you get from number 3, where everything going over to the right side is damaged, and therefore everything on the left side of my visual field should be lost. The unique thing that happens in number 6, however, is that it's very hard to knock out all of the neurons that are responsible for the center of visual field, because there's so many neurons that are subserving vision for the central vision that even if I have a stroke in that area, it's likely that I'm going to have some sparing of that macula. So what happens with number 6 is that I get a hemianopsia, but I have a little bit of sparing of vision in the very center of vision. So that's called a homonymous hemianopsia with macular sparing. And if it's on the right side, it would be a left homonymous hemianopsia with macular sparing. So here are the projections from the LGN to the visual cortex. And this is a way to look at this. You can see Myers loop wraps all the way around, even to the tip of the hippocampus, into the temporal lobe. These are the visual field deficits that you would see with each of those lesions that we just described. Number 1 is a right monocular blindness. Number 2 is a bitemporal hemianopsia. Number 3 is a left homonymous hemianopsia. Number 4 is a left superior quadrantinopia. And number 5 is a left inferior homonymous hemianopsia. Homonymous quadrantinopsia. So number 5 is a left inferior homonymous quadrantinopsia. And number 6 is a left homonymous hemianopsia with macular sparing. They correspond to the lesions that we just talked about. And again, you can start with these lesions and determine what brain damage occurred. Looking at number 3, you know that everything on the left side of the visual field is damaged, so therefore everything going to the right side of the brain must be damaged. Number 4, everything in the left superior portion of the visual field is damaged, therefore everything down and to the right in the brain is damaged. So that would correspond to right Myers loop. Number 5, my visual field is damaged in my left inferior quadrant, therefore things in my right superior quadrant of my brain must be damaged. That would be something like my right superior optic radiations or my right cuneate gyrus. Let's do some clinical vignettes. A 79-year-old white woman complains of a throbbing unilateral headache that is most severe around her forehead and temples. She has had recurrent bouts of fever over the past year and also complains of malaise and muscle aches. She reports some weight loss and occasional vision problems in her right eye. She also reports pain in her mandible when she is eating, jaw claudication. On physical exam, she has fever and nodular enlargement of the temporal artery with tenderness. So if you have an elderly woman like this with a throbbing unilateral headache and periods of loss of vision in that same eye, this is very suggestive of giant cell arteritis or temporal arteritis. So a couple of things that we can look at are an ESR, which would suggest an elevation of inflammation in the blood. So an erythrocyte sedimentation rate is what we could measure. Although in this situation, even if she has such a classic presentation, even if the ESR were not elevated, we would probably still suggest that this is temporal arteritis. Well, and in this case, they proceeded with a temporal artery biopsy, and you saw a swollen, cord-like, segmentally nodular temporal artery. This is what you would see with a temporal artery biopsy. On the micropathology, you see a granulomatous inflammation of the media and adventitia of the temporal artery. You see a multinucleated giant cells and fibrotic patches. So this is important to treat with steroids. This is the only way that you can really make sure that the vision will be saved, and these people are even at risk for stroke because this vasculitis can start interfering with blood flow to the brain. So it's important to start steroids in these patients, which is sometimes a difficult decision because these elderly patients do not always tolerate steroids very well, but it's really your only choice in this case. This concludes this section of the neurology review for USMLE Step 1, Falcon Physician.